Thank you very much. May I congratulate the Vertigoty Foundation for an excellent conference. After Anand Kumar's talk, I thought I would rename PSA, that's fine, thank you very much. I would rename PSA as prostatitis specific antigen. And, let me take you, tell you a little story here. The story goes like this. I grew up amongst my bosses, the greats like John Blandy, who always believed that prostate cancer had to be treated with radiation. I grew up with Roger Kirby, who was about 20 years older than I, who was preaching at every bouse that we needed to do more radical prostatectomy. And young people like me sat there thinking, is there really an answer to this? Particularly having come from the subcontinent where there was hardly any prostate cancer that we could see in our training period. And then, 3 years ago, this happened. I was on a flight to Vienna. I opened the Telegraph, and there was the European randomized trial of screening for prostate cancer. We were all expecting it, and lo and behold, it said this: 20% benefit in saving lives. And I thought, no one is ever going to say that these are not European patients, and therefore the UK government, unlike what it had done in the past, would be forced to accept PSA screening. How wrong was I? The very next week, I was invited to this building, the Royal Society of Medicine. And in that building, in a room much smaller than this, were 10 people at breakfast, 7 a.m. in the morning. I was one of 10 people. And that man in the center wasn't Henry VIII. It was the editor of the New England Journal of Medicine. And there we were, trying to talk to him about the randomized control trial that had been published, the largest one of its kind. Equally, there were people on the other side of the same breakfast table who were talking about the PLCO trial, which had been published in the same edition of the journal. And may I say to my American colleagues, it should never have been. There were problems. The PLCO trial, done in the United States, which had always advocated PSA screening in men above the age of 50, or even younger, in men who had a family history of prostate cancer, suddenly threw it all out. No benefit at all. And yet, at 7 years, almost half of the men had a crossover. There was a contamination of the data. And I repeatedly asked the editor of the New England Journal of Medicine, the best journal in our specialty anywhere in the world, as to how two completely conflicting studies have been published. The next day, the UK government released a statement saying PSA screening was still controversial. What a complete waste of time, and what a complete waste of billions of pounds, dollars, euros, and may I say, rupees as well. And this was that classic paper from Fritz Schroeder, which I thought, as many did, would change clinical practice, but it didn't. Is it any surprise that when we do surgical science, the Lancet says this is comic opera? Even after a trial like this, we have no answers. This is what PSA is a bit like. If you line up soldiers from their heights to the shortest to the tallest and send them to battle, you will find a random distribution. And the risk of having prostate cancer is a bit like that random distribution somewhere there. In fact, PSA is not very good at all. But here is my first message. If you have a PSA of less than 1, when you are less than 50, it's very unlikely that you will get prostate cancer in your lifetime. So if there's one thing you do to prove that your risk is low, have a single PSA before the age of 50, and then forget about it. What are the 3 key facts with PSA? What is it actually going to achieve for our patients? Firstly, diagnosis. Well, it's not good enough. Second, treatment. And perhaps it does have a role, not in treatment, but in post-treatment follow-up. And again, I'll discuss the controversies there. And finally, in the monitoring of the post-treatment patient. So this is what's happening in prostate cancer in the United Kingdom. Very similar to what was happening here. And in fact, our statistics 20 years ago, when I was training, are very similar to what's happening here in India now. 35,000 men diagnosed every year, 10,000 of them die. Commonest cancer in men over the age of 50. In fact, a lot of my patients, about 30%, are now less than 50, young men in their 40s. And guess what? I practice in Guy's, which is in one of the poorest parts of London, southeast London. 1/3 of my patients can't even pronounce their names properly. They've never heard of the PSA test. It's absolutely true. It's very different from the private practice in Harley Street, where almost 90% of the men are screened and have a diagnosis before they come in. Only 6% of British men, unlike 60% of their American counterparts, ever ask or have a PSA test. We are not much better than the men in India or much better than the men in New Delhi. The problem is not the PSA. As Kunra said, it's not PSA. The much bigger problem is obesity. And if there's one message I would like to give to our patients, and this is what I say, look, if you're fat, there's no point in me operating on your prostate cancer. Drop your weight, come back 6 weeks later, thankfully they do, and if you do manage to lose your weight, I'll do a robotic radical prostatectomy on you. If you don't, there's no point, because your weight is a greater threat to you than your prostate cancer is. I do look at free to total ratios, particularly in men who have repeated negative biopsies, but a free to total ratio of less than 0.15. The problem of free to total ratio is simply this. There is no cut point of the total PSA which has a high enough sensitivity or high enough specificity to give reassurance to my patients. So what else is out there for these patients with whom I have a problem? Firstly, the PCA3 gene test. Some of you may have heard about it. I do not know whether it is available in India, but the way technology is going, you seem to have more cyber knives here than we do. So I'm sure somewhere in New Delhi, you have the PCA3 gene test. For those of you who are not familiar, the patient has a prostate massage in clinic, and the next urine is sent off to the local lab, and you get a readout in about a week's time. And if the PCA3 score is more than 35, which is the cutoff, then the chance of having a repeat biopsy showing a positive diagnosis of prostate cancer, and this is typically a template biopsy, transperineal, this is not a truss-guided biopsy or a transfecal biopsy, may I say so, is significant in those patients compared to those who have a PCA3 of less than 35. Here is the other paradigm shift that has happened in these patients. Where a PSA has failed to make a diagnosis, repeated biopsies are positive. I do a 3 Tesla MRI. I'm sure, again, this technology is already in India. And the paradigm shift that is happening with prostate mapping, not just PSA, is a 3 Tesla MRI being negative or showing a focus of cancer which you can aggressively biopsy apart from the normal areas of the prostate. And I think this is the way the diagnostics is going. It is no longer just the PSA test. We are also doing a lot of active surveillance. Just as the era of doing more and more radical prostatectomy happened, we realized that we did not need to remove the prostate in every patient. A lot of young men now are having active surveillance because they have a tiny focus of cancer. They're married to a beautiful Italian woman, and they do not want to have the problem of erectile dysfunction. Again, 30% of these men eventually go on to have radical therapy. I think the PSA in this group of patients is particularly beneficial. But what about the other problem that has come with ultrasensitive PSA? I had just last week a colleague general practitioner on whom I had done a radical prostatectomy. So 3 months ago, he had a regular PSA at his own surgery, and that was less than 0.1. 3 months later, he comes to me saying, look, I went to the lab around the corner, and they did an ultra-sensitive PSA is less than 0.03. And then 3 months on, you know what he did? He had an ultra-sensitive PSA, and this was less than 0.004. And he came to me and said, surely there are a few cancer cells making signals in my body because it has gone from less than 0.003 to less than 0.004. Now, the problem here is major. If you go to Hopkins and you have a PSA post-op of less than 0.1, you're fine. I don't think Pat Walsh or anyone else is going to do anything about that patient. The problem is patients going from lab A to lab B to lab C having more and more and more ultrasensitive PSA tests. And this is something we are addressing in the Radicals randomized trial. I'll speak about randomized trials tomorrow as to why and when we need to target the patient where there's a PSA rise. What is the cutoff of an ultrasensitive PSA that lets you detect a return of the cancer which needs to be treated before the PSA climbs to over 0.1? The answer is no one knows, but this is causing patients a lot of stress, and it is getting labs around the corner to make a lot of money. This is where I think we are really going. It is no longer just the PSA, it is an attempt to make the PSA better. I was very pleased that Ashutosh Tiwari mentioned breast cancer. There are real parallels between breast cancer on one hand, PSA, and prostate cancer on the other. Look at these men on the right who had just had a PSA test and what their prostate cancer risk is, and if they are BRCA1 or worse still, BRCA2 positive. I have patients who not only have prostate cancer, men, but also other cancers, including breast cancer. I know they're rare, but these people have dreadful disease. If you actually look at the relationship of the BRCA1 and 2 genes as signals, they perform better than the PSA test. If you have BRCA2 positive or mutated BRCA2, you might as well call it quits, go to a Caribbean island and enjoy yourself. Whatever anyone does to you, your life expectancy is pretty poor. And these are the ways you can tell between the Blandian principles of the pussycat versus the tiger. I'm sick of it, man. Every time I go to a conference on my island, someone is talking about, oh, we can't talk about the pussycat and the tiger. 25 years have gone by. We need to get real. The biomarkers for saying which is a deadly cancer is just around the corner. It's just around the corner because of Ross Eales from the Institute of Cancer Research, who embarked on what are known as genome-wide association studies. Now, while this might sound amazing to you, all it involves is a pretty simple assessment of something that is just the size of your fingernail. So you have gene chips by which you can look at differences in the genetic signal of patients who have prostate cancer versus control. So these are 4,000 patients, each arm, some from the Protect-T trial, which compares active surveillance, radical surgery, radical radiotherapy, all in the United Kingdom, and case matched with patients in Adelaide and other parts of Australia who do not have prostate cancer. And what you look at is known as single nucleotide polymorphisms, or SNPs. And this is again published in Nature Genetics from Ross Eales and our group, showing that there are 29 loci of prostate cancer, even in men who do not have hereditary disease. And I think this is where PSA is going. The good news is that we have reasons to be cheerful. PSA is getting better. If you look at just PSA and assess how good it is, you look at the area under the curve. The better the area under the curve, the better is the test at a diagnostic and a therapeutic option. Currently, that area under the curve is only 57% with PSA alone, whether you look at it in India, in United Kingdom, or United States. It's no better than 57%, just like tossing a coin.